The oxygen hemoglobin dissociation curve is another high-yield concept that you will definitely see on the boards. Recall from our discussion of hemoglobin that the binding and unloading of oxygen from hemoglobin shows cooperativity, resulting in a sigmoidal shape of the dissociation curve. So how does this compare to myoglobin? Well, myoglobin is a monomeric heme protein, similar to the alpha subunit of hemoglobin. Because it's monomeric, instead of hemoglobin's multimer, is not capable of having these quaternary structural shifts mediated by allosteric interactions. So, as you can see here, myoglobin has a hyperbolic, non-sigmoidal curve. But it also has a greater affinity for oxygen than hemoglobin. Interestingly, the hemoglobin curve can shift right or left under specific conditions. So why would the curve shift, and why would you care? A shift in the curve in any direction simply means that there is a change in the affinity of hemoglobin for oxygen. A shift to the right signifies a decreased affinity of hemoglobin for oxygen. What this means is that there is more unloading of oxygen into the tissues. Think for a moment about situations where this would be pretty helpful. For example, when you're exercising, your muscles need more oxygen, so it makes sense that the curve shifts to the right, meaning that hemoglobin at the same partial pressure of oxygen will be less saturated, since oxygen is being unloaded in the tissue. So there are a number of factors that will shift the curve to the right. The mnemonic to keep in mind is C-beat. CO2, 2,3-bisphosphoglycerate, exercise, acid, altitude, and temperature. What do all these factors have in common? They all signal a need for more oxygen delivery to the tissues, and they all stabilize the T or taut form of hemoglobin over the R or relaxed form. And this allows hemoglobin to better unload oxygen in tissues. So this makes sense, right? Active muscles, like during exercise, locally cause an increase in local temperature, increased CO2, and increased acidity. 2,3-BPG is synthesized in red blood cells from 1,3-BPG. And 1,3-BPG should sound pretty familiar. Do you recall from where? 1,3-BPG is an intermediate in glycolysis. So actually, making 2,3-BPG costs the red blood cell 1 ATP that it otherwise would have gained from converting 1,3-BPG to 3-phosphoglycerate. But the body gets a molecule that is critical in shifting the dissociation curve when it needs more oxygen. Besides at high altitude, when does the body make more 2,3-BPG? You usually see more 2,3-BPG when there is tissue hypoxia, like in COPD and in CHF, which you saw in cardiology. Not surprisingly, if you decrease these C-beat factors, you can get a left shift of the curve, which means increased affinity of hemoglobin for oxygen, thus less unloading of oxygen to the tissues. As we discussed earlier, fetal hemoglobin also shifts the curve to the left because it has a higher affinity for oxygen than adult hemoglobin. Why is this important? The fetus needs to steal oxygen from mom's adult hemoglobin. This is mainly because fetal hemoglobin has a low affinity for 2,3-BPG. So at baseline, the dissociation curve is shifted to the left, and hence increased oxygen affinity. Finally, as we just discussed, carbon monoxide shifts the curve to the left, but ultimately limits its carrying capacity because it binds the oxygen site. Let's have a flash quiz. What is the effect of carbon monoxide on hemoglobin? A left-shifted binding curve, but decreased oxygen capacity because it binds to the oxygen site. Next, let's talk about oxygen content in the blood. As you know, oxygen in blood is either bound to hemoglobin or dissolved in the serum. But where is more oxygen carried? Bound to the hemoglobin. Normally, 1 gram of hemoglobin binds 1.34 milliliters of oxygen. Assuming a normal concentration of hemoglobin to be 15 grams per deciliter, how much oxygen is bound to hemoglobin? Doing the math, the answer is about 20.1 mils per deciliter. It's no surprise that the absolute oxygen content of arterial blood decreases as hemoglobin falls. You're losing your major carrier. However, you won't be able to tell that from the O2 saturation and arterial PO2, which can remain high. So, what did we just talk about that can decrease arterial PO2? Remember, chronic lung diseases like pulmonary fibrosis and emphysema can limit diffusion of oxygen and decrease arterial PO2. Bonus question. What can lower venous PO2 even if you have a normal arterial PO2? The answer is exercise, and we'll talk more about exercise at the end of this section. Let's work through this table together. Do you recall from the hematology section what polycythemia is? That's right, high hemoglobin levels due to red blood cell proliferation. Let's look at anemia and polycythemia first. Is the hemoglobin itself affected? No, so the oxygen per gram of hemoglobin will be normal. What about the dissolved oxygen? This is also normal, since nothing in the serum has changed either. Now, in a single unit of blood, what happens to the hemoglobin level? In anemia, you have fewer red blood cells and fewer molecules of hemoglobin, so the binding capacity decreases. Just the opposite happens in polycythemia, where you have more red blood cells and more hemoglobin. What about the total oxygen content? Well, in anemia, the total oxygen content is decreased, whereas in polycythemia, it will be increased. So, what's different about carbon monoxide poisoning? The hemoglobin itself is directly modified. So, less oxygen actually binds each hemoglobin molecule. What do you suppose happens to the total oxygen content? It decreases. And what about the hemoglobin level? It's normal. It's just the oxygen sites are occupied by tightly binding competing carbon monoxide. And what about the dissolved oxygen? That's normal, because the serum isn't affected. The oxygen and carbon dioxide content of blood each have different effects on pulmonary and systemic circulation. This is an important concept to understand, as it will help you reason through situations where you may not have an immediate answer. Let's look at oxygen. A decrease in alveolar PO2 will shunt blood away from the less ventilated regions in the lung. This makes sense, right? Because it conserves energy by only circulating blood to areas with oxygen. But too much of a good thing can lead to pulmonary hypertension, which we'll discuss later in the pathology section. Another important concept to understand is when and how gas exchange is limited, either by diffusion or perfusion. What's normally the limiting factor in gas exchange, diffusion or perfusion? In healthy individuals, gas exchange is limited by perfusion. So, what does perfusion limited mean? Here, gas equilibrates early along the length of the capillary, and you can only get more oxygen into the blood by increasing the blood flow. Normally, oxygen, CO2, and nitrous oxide are perfusion limited. This is represented here, where you can see that the pressure of a given gas in the blood and in the alveolar air reach an equilibrium very quickly, and no further gas exchange occurs while that same blood is in the pulmonary capillary. Contrast this with a molecule that is diffusion limited, like carbon monoxide. The release of carbon monoxide from the blood is slow, and is dependent upon the amount of time it has to work its way out of the blood and into the alveoli. What governs this type of diffusion? Take a look at this equation. Here, A is area, T is thickness, and this whole term is the difference in partial pressures. Now, for carbon monoxide, blood is not in the pulmonary capillaries long enough to reach equilibrium with the alveolar air, as represented by this gap. So, when else does gas exchange behave this way? Carbon monoxide, obviously, and pathologic states, in which the gas either has a smaller surface area to diffuse across, such as in emphysema, or has to diffuse across a thicker membrane, such as with pulmonary fibrosis. You can see the same concepts here with oxygen. In exercise, the equilibration occurs late along the length of the pulmonary capillary. So what's going on? The heart is pumping, and the velocity of the blood is increased through the capillary bed, so there's less time for the oxygen to equilibrate. We're now going to discuss pulmonary vascular resistance. The key here is to understand the relationships among resistance, pressure, and flow. Does this concept sound familiar? This is pretty much the resistance, pressure, and flow fact discussed in the cardiovascular physiology section, so you might want to go back and check it out. Again, it's not necessary to memorize the equations, but you do have to understand the relationships. Resistance equals the pressure gradient divided by the flow. In this case, R is the pulmonary vascular resistance. The pressure gradient, or delta P, is the difference in pressure between the pulmonary artery and the left atrium, and Q, or flow, is the cardiac output. Pulmonary vascular resistance is directly proportional to viscosity, which can be represented by the Greek letter eta, and inversely proportional to the radius raised to the fourth power. This means that the radius is the most important factor contributing to resistance. So it makes sense that the pulmonary arterioles contribute the most to pulmonary vascular resistance. This is because they have the least total cross-sectional area in the pulmonary circulation. Flash quiz. On which aspect of circulation is pulmonary vascular resistance most dependent? The radius, because it's raised to the fourth in the denominator. The alveolar gas equation is used to calculate the alveolar arterial gradient, or the AA gradient, which is useful when trying to figure out the cause of hypoxemia, which we'll discuss next. PA is the alveolar oxygen partial pressure. PI is the partial pressure of oxygen in inspired air, and PaCO2 is the carbon dioxide in the arteries. R is the respiratory quotient, or 0.8. Ultimately, you can estimate the PaO2 by knowing the PaCO2 from the arterial blood gas. So, what's normal PaO2 for a healthy adult at sea level? Well, the normal PaCO2 value is about 40 millimeters of mercury. So, divide that by 0.8 gives you 50, and finally a PaO2 of 100 millimeters of mercury. What's the bottom line? If you see an AA gradient that's greater than 15 millimeters of mercury and with hypoxemia, you should be thinking about some sort of right to left shunt, VQ mismatch, or a diffusion limitation problem, like we just discussed. Flash quiz. What disease states cause diffusion limitation? Emphysema and cystic fibrosis. Emphysema decreases the surface area, and cystic fibrosis increases the thickness of the membrane. This is a useful framework for understanding the various scenarios in which not enough oxygen gets to the tissues. There are three specific scenarios you need to know about: hypoxemia, hypoxia, and ischemia. First, hypoxemia occurs when the partial pressure of arterial oxygen is decreased. That is, the oxygen content in the aorta is lower than normal. It can be caused by things that decrease the amount of oxygen that enters the lungs with a normal AA gradient, such as high altitude or alveolar hypoventilation, or by things that prevent the oxygen in the lungs from entering the blood, such as a high AA gradient. This could include VQ mismatch, impaired diffusion, or a right to left shunt. A right to left shunt might include what kinds of problems? Well, it could be anatomic, like tetralogy of Fallot, which could have a VSD, where low oxygen content blood goes out through the aorta. Or it could be physiologic, like pulmonary edema. In pulmonary edema, blood is flowing through the lungs, but all of the edema in the alveoli block gas exchange, so blood returns to the left side of the heart without getting oxygenated. Hypoxia is the condition in which there is decreased oxygen delivery to the tissues, which can result from hypoxemia, like we just discussed, or from other factors, such as decreased cardiac output or carbon monoxide poisoning. So here's a question for you. What's the most common cause of decreased oxygen content in the blood in the setting of normal oxygen saturation? The answer would be anemia. In addition to carbon monoxide poisoning, we should also add methemoglobinemia. As you recall, it causes a functional anemia because the methemoglobin does not bind oxygen as well as regular hemoglobin does. Finally, ischemia is caused by a loss of blood flow to a particular tissue or organ, and thus the absence of oxygen availability. This can be caused by something that impedes blood flow, such as an embolus or a clot, or by something that decreases venous drainage. If blood can't exit a capillary bed, then no blood can enter it either.